So, carbachol, bethanochol, and methacholine were the esters of choline. Now we'll have a look at the cholinomycetic alkaloids and the miscellaneous agents. If you look at this slide, the first one is pilocarpine, and this is used as eye drops in the open angle glaucoma. Down, I am showing two agents which are miscellaneous agents, that's cevimeline and oxytramorine. All the three agents are mainly used in the management of xerostomia, that's the dryness of mouth. It could be used to decrease the dryness of mouth in patients after radiation for head neck tumors, or it could be also useful to decrease the dryness in the patients with Sjogren syndrome. Let's discuss the adverse effects of cholinergic drugs. When we said cholinergic drugs, we said they are directly acting and indirectly acting, and the adverse effects are going to be applicable to all the agents because it's going to be cholinergic excess. So if there's excess acetylcholine, the first adverse effect is going to lead to bronchospasm, that's the contraction of the smooth muscle of the bronchus. It could also lead to abdominal cramps. NVD is nausea, vomiting, and diarrhea. Because acetylcholine increases the secretions, you could get salivation, lacrimation, and sweating. Because acetylcholine has got an action on the muscarinic receptor sites in the sphincter pupillae, is going to lead to miosis, spasm of accommodation, and blurring of vision. It could lead to flushing, and its effect on the heart could lead to myocardial suppression, leading to bradycardia and hypotension. The effects on the nicotinic receptor side is going to be due to the effect on the skeletal neuromuscular junction, and this could lead to fasciculations and paralysis. Now we go to the indirectly acting cholinergic drugs. Why do we call them as indirectly acting? The first group was directly acting, means they were combining with the cholinergic receptor and they were acting as agonist of the cholinergic receptor. Whereas indirectly acting agents are not expected to be the agonist of the cholinergic receptor. What is this indirect action? This indirect action is anti-cholinesterase effect or anti-cholinesterase action, and that's why we call them anti-cholinesterase agents. Look at the slide. Acetylcholine is getting degraded with the help of the enzyme cholinesterase, and I've shown the sign of inhibition on this reaction. This is where the anti-cholinesterase agents are going to act. They are going to combine with the cholinesterase enzyme, and they are going to stop the cholinesterase enzyme from breaking down acetylcholine. And this is why the end result is going to be less degradation, less breakdown of acetylcholine, leading to accumulation of acetylcholine. So they inhibit the breakdown of acetylcholine, and it leads to what is called as reinforcement, potentiation, amplification, or accumulation of acetylcholine. Where is it going to happen? It's going to happen at all cholinergic sites. That's going to be the muscarinic receptors as well as the nicotinic receptors. We're going to get excess of acetylcholine. And this is why I said, let it be an indirectly acting agent or directly acting agent, is going to lead to the more cholinergic transmission. So the effects will be like acetylcholine, and the adverse effects also will be like the adverse effects of acetylcholine. So all the actions will be those of acetylcholine. Now let's try to describe the anti-cholinesterase agents. They are divided into reversible and irreversible. What's this reversible and irreversible about? This is about the inhibition of the cholinesterase enzyme. If a drug is producing reversible inhibition, we call them as reversible anti-cholinesterase agents, and the other ones will be irreversible anti-cholinesterase agents. Let's have a look at this slide and concentrate on the slide. On the left hand side, in the left column, I'm showing the reversible agents, and these reversible agents are carbamate in structure. They are carbamates in structure, so they carbamylate the esteratic site of the enzyme. By the way, the enzyme has two sites, esteratic site and anionic site, and the carbamates carbamylate the esteratic site. When this site is carbamylated, the recovery from inhibition is quite slow. But still, you can reverse the inhibition, and that's why it's called reversible inhibition. Let's try to go to the other side and understand what's irreversible. Irreversible anti-cholinesterase agents are organophosphorus compounds. And instead of carbamylation, they phosphorylate the esteratic site. The word is important. They phosphorylate the esteratic site. The same esteratic site, but they don't carbamylate. They phosphorylate. And they phosphorylate in such a way that the recovery from this particular effect is extremely slow. And this is why it's difficult to reverse the inhibition. So we call this as irreversible inhibition. Is there an implication of this irreversible inhibition? Yes, there is. When you get an organophosphorus compound poisoning, we're going to use the drugs called oximes, which are supposed to regenerate or reactivate the cholinesterase enzyme. And these oximes, they combine with the free site, that's the anionic site. We already said the organophosphorus compounds phosphorylate the esteratic site. So the anionic site is free. The oximes go to the anionic site, combine with the anionic site, and they free the organophosphates from the esteratic site. This is how we are going to get the inhibition. So that's the purpose of knowing the phosphorylation of esteratic site. If you go down on the same side, there's a right side, there's a second group of irreversible agents, and they are also called carbamates because they carbamylate. But what's the difference? These carbamates, that's the irreversible carbamates, they combine with both esteratic as well as anionic site. The compounds are carbaryl, DDT, endrin, and bigon. So what's going to happen is these substances are going to sit on the esteratic site as well as the anionic site. And naturally, if you try to give oximes to reverse this poisoning, the oximes have no place for action. The anionic site is not free because the carbamates are combined with both esteratic and anionic site. So the site is not available for oximes to act. So if you get a poisoning by the carbamates, it's difficult to reverse this particular poisoning by using the oximes. So that's very important about the irreversible anti-cholinesterase agents. Let's come back to the left side and have a look at the reversible agents once again. We already described how they act. Let's know which are these agents. This is physostigmine, neostigmine, pyridostigmine, ambinonium. All these four agents are useful in the management of myasthenia gravis, and they are also useful for some other situations. Down, I am showing three agents, that's rivastigmine, donepezil, and galantamine. These are also anti-cholinesterase agents, reversible, and they are used in the management of Alzheimer's disease. Down you see two drugs written in blue letters. And what's the implication? Here you have edrophonium and tracrin, and the speciality of these drugs is they are combining with the anionic site, and it's comparatively easy to free them from the anionic site, and this is why they produce a short duration of action. So, edrophonium combines with the anionic site, and this is why it produces a rapid action and produces a short duration of action. Now let's discuss the reversible anti-cholinesterase agents in details. Let's again have a look at the slide. You have a natural agent which is called physostigmine, and you also have a synthetic agent called neostigmine. Especially to talk about physostigmine, this physostigmine is able to cross the blood-brain barrier, and that's why it's useful to treat the overdoses by atropine, or what you call datura poisoning, the overdose by tricyclic antidepressants, the overdose by antihistaminics, and the physostigmine also could be useful in the management of glaucoma. Its very important character is it can cross the blood-brain barrier. The synthetic substance neostigmine is mainly useful in the management of myasthenia gravis for post-operative decurarization and for cobrapide. The reason for this is neostigmine doesn't cross the blood-brain barrier, one, and secondly, it's got a direct agonistic action on the nicotinic receptor. Two other substances, pyridostigmine, ambinonium, and edrophonium, are also frequently used in the management of myasthenia. I am again repeating about edrophonium, which is used for a test in the dose of 2 mg by intravenous route of administration called Edrophonium Test. It combines with the anionic site, that's why you have a rapid action and you have a short duration of action. This slide at the end describes about Alzheimer's disease, and The proposition that increase in the amount of acetylcholine could help the patients with Alzheimer's disease, we have anti-cholinesterase agents which could be used for the management of Alzheimer's disease. You have the first one, rivastigmine, which is selective for the G1 isoform of the cholinesterase enzyme and it's got a long action. The next one is donepezil, which is the most preferred agent, is cerebroselective, has got minimal peripheral adverse effects and has got a long half-life. The third one is galantamine, which is an alkaloid and it also inhibits the cerebral acetylcholinesterase enzyme. The last one shown, tacrin, is not preferred nowadays. The indirectly acting anti-cholinesterase agents, which are irreversible, are, as you know, are divided into organophosphates and the carbamates. Look at the slide. To remind you, organophosphates combine with the esteratic site and carbamates combine with anionic as well as esteratic, both the sides. Organophosphates are malathion, parathion, DFP, that's diflos, diazinon, that's TIC20, and there are three nerve gases, tabun, serine, and soman. All these are the organophosphates. There is one organophosphate which is irreversible anti-cholinesterase agent is ecothiopate, which could be useful in glaucoma because it's got a long action of 1 week. As far as the carbamates are concerned, you have carbaryl, DDT, endrin, and bygone. If you look at all these substances, you would understand most of them are insecticides, and a country in which agriculture is a major profession, this insecticidal poisoning is one of the most common poisonings. It could be an accidental poisoning or it could be unintentional. Let's come to the discussion of the organophosphate or organophosphorus compound poisoning. As we know, they phosphorylate the esteratic site of the enzyme. And once you start producing an anti-cholinesterase effect, acetylcholine is going to accumulate at all muscarinic and nicotinic receptor sites. So the manifestations that you would get would be the manifestations of acetylcholine. And naturally, this patient gets meiosis and spasm of accommodation, leading to blurriness of vision. Is likely to get bronchospasm because of the contraction of the bronchial smooth muscle. Because the secretions are more, there will be salivation and sweating, and there could also be vomiting and diarrhea. The effect on the muscarinic receptor in the heart will be that of myocardial suppression, and that's why the patient would get AV block. With all these manifestations, what has happened is acetylcholine is accumulating at the muscarinic and at the nicotinic receptor site. We have two approaches. Number one, could we do something so that the muscarinic effects could be blocked or muscarinic effects could be reversed? Yes, we have a muscarinic blocker, a selective muscarinic blocker. That's nothing but atropine. Atropine is given in the dose of 2 to 3 milligrams intravenously initially to block the muscarinic actions of this excess acetylcholine. And when atropine is given, atropine will have competitive inhibition, competitive antagonism with the accumulated acetylcholine, and it will start liberating, displacing acetylcholine from the muscarinic sites. Once this starts, the pupil of the patient will start getting dilated. And this is why you can monitor the size of the pupil and you can decide if you have given adequate atropine to the patient or not. The second approach, a more rational approach, could be to remove the cholinesterase enzyme inhibition. And this is why we have drugs called oximes. I already made a mention of it. These are pralidoxime, is also called PAM or P2AM. You have obidoxime and you have diacetyl monoxime, that's DAM. What are they doing? As we said it on the first slide, they combine with the anionic site. Anionic site is free. The organophosphorus compound has combined with the other site, and that is esteratic site. So anionic site is free. The oximes go and combine with the anionic site, produce a change, and make the esteratic site free. Once the esteratic site is made free, there is displacement of the phosphate group of organophosphates and the cholinesterase enzyme is free. Once the cholinesterase enzyme is free, it can start breaking down the acetylcholine which is accumulated. And this is why, because oximes are regenerating or reactivating the cholinesterase enzyme, they are called cholinesterase enzyme regenerators or cholinesterase reactivators. So organophosphorus compound poisoning is managed with number 1 anti-muscarinic, that's atropine, and the cholinesterase reactivators or regenerators, what we call as enzymes. At the end of this organophosphorus compound discussion, I would like to highlight 2 agents which are reversible anti-cholinesterase agents, and they were physostigmine and neostigmine. And this particular comparison between physostigmine and neostigmine could be useful to you to solve some of your important questions. Physostigmine I have shown on this slide on the left side. Please have a look at the slide. And neostigmine is in the right column. As we already said, physostigmine is natural and neostigmine is synthetic. Physostigmine is a tertiary amine, whereas neostigmine is a quaternary amine. Quaternary is 4. Once you say the drug is tertiary amine, this structure gives it some properties, some important properties. And the most important property which physostigmine gains is it becomes a more lipid-soluble agent. It's a more lipid-soluble agent. And because it's more lipid-soluble, it can penetrate the eye. So coming to the next row, it's useful locally in the management of glaucoma. And because it's more lipid-soluble, it can have better penetration across the blood-brain barrier. Once we know that it has better penetration across the blood-brain barrier, I'm taking this arrow straightway down to show you the application, the implication of crossing the blood-brain barrier. Physostigmine is useful to treat overdose with atropine because atropine crosses blood-brain barrier and blocks the muscarinic receptors in the CNS. Physostigmine could follow it, it could penetrate the blood-brain barrier and remove atropine from the blocked sites. So physostigmine is useful to reverse the central effects not only of atropine overdose but also of overdose with antihistamines, overdose with phenothiazines, and overdose with tricyclic antidepressants. So it's a very important property to reverse the central nervous system effects in all these poisonings. Coming to the right side now, neostigmine is less lipid soluble, so you don't expect it to be used in the management of glaucoma because it would not penetrate. It's got less penetration across blood-brain barrier, so you won't expect it to be used for the central nervous system effects. Whereas neostigmine has got a special property. It is originally an anti-cholinesterase agent, but in addition to this, it's got an additional direct action on the nicotinic receptor. What is this direct action? This direct action is action like acetylcholine. That's the agonistic effect. It means neostigmine has got indirect action of inhibiting the enzyme cholinesterase and concentrating acetylcholine. In addition to this, it also has a direct action on the nicotinic receptor, that's the skeletal neuromuscular junction. And I'm taking the arrow down to show you immediately the implication. This is why neostigmine is a better choice as far as the management of myasthenia gravis is concerned, because myasthenia is a condition which is associated with the skeletal neuromuscular junction, that's the nicotinic receptor. So neostigmine is going to produce a better effect due to this direct agonistic activity. In addition to this, when you give neuromuscular blocking agents during a surgery, at the end of the surgery, you want this block, a neuromuscular block, to get reversed. You want the skeletal muscles of the patient to be active as normal. And this is why sometimes you need to decurarize. You need to give an agent which is going to displace the neuromuscular blocking agent from the nicotinic site and will free the skeletal muscles. And this is called post-operative decurarization. You could use neostigmine for this purpose. When neostigmine is given, it's going to pour in acetylcholine at the nicotinic sites as well as muscarinic sites. We don't want the muscarinic effects, so you can give atropine to block the muscarinic effects. So that's the usual way, using an anti-cholinesterase agent for the nicotinic effects and giving atropine to block the muscarinic effects. This stands true for myasthenia. This also stands true for the post-operative decurarization. One point, important point here, this neostigmine is useful in post-operative decurarization, but later we got a new agent, and that's your edrophonium, which is rapidly acting, which is short acting. So edrophonium is going to be better as far as rapid reversal of the neuromuscular blockade. So also, these two agents could be useful to manage the toxicity with the neuromuscular blocking agents. Coming down to the row of the CNS effects, as compared to physostigmine, because neostigmine doesn't cross the blood-brain barrier much. It is not going to have central nervous system effects, so it's going to be less useful to reverse the CNS effects of all these overdoses. So again, physostigmine becomes a drug of choice to treat the overdoses with atropine, antihistamines, phenothiazines, and tricyclic antidepressant drugs. We need to know something about myasthenia gravis. So here's some important information about myasthenia. Mya is muscle, asthenia is weakness, and gravis because it's a serious condition. There's impaired synaptic transmission across the skeletal neuromuscular junction in myasthenia. What could be reasons? In 85% of the cases, there's an autoimmune basis, and there's a specific human leukocyte antigen, that's HLA haplotype A1B8DW3 demonstrated in these patients. In addition to this, the patients could have concurrent hyperplasia or tumors of thymus, and there's a raised antibody titer to the acetylcholine receptor. This is seen in 85% of the cases. Whereas in the rest of the 15% patients, it's a heterogeneous condition. There's no antibody demonstrated to the acetylcholine receptor, but the antibodies may be present to the muscle-specific kinase, which is a neuromuscular junction protein. So this is about etiology of the myasthenia gravis. What are the approaches to treat? Since we know the immunological basis, the first purpose is immunosuppression. The first approach is immunosuppression. That's eliminating the autoreceptor antibodies. Corticosteroids, azathioprine, intermittent plasmapheresis, and IV immunoglobulin. These are the approaches, and these drugs could be useful for immunosuppression. The second approach is thymectomy for the patients who are less than 40 years of age. And the third approach is what we are discussing, the drug therapy by giving anti-cholinesterase agents. The agent which is preferred is pyridostigmine, that's most commonly used, or you can use neostigmine. And because these agents are going to pour in acetylcholine at the nicotinic receptor, this is going to be the beneficial effect in myasthenia. At the same time, we cannot forget that acetylcholine will also increase at the muscarinic receptors, and to block this particular muscarinic adverse effects, we could add propantholin or atropine to block the muscarinic adverse effects. How is myasthenia diagnosed? The first test, which is most commonly used for diagnosis of myasthenia, is called Edrophonium Test. Edrophonium is injected by intravenous route of administration in the dose of 2 milligrams, and the test is called ameliorative test. Edrophonium is an anti-cholinesterase agent acting very rapidly. Suppose we presume this patient has myasthenia, is likely to have less acetylcholine at the neuromuscular junction. When you give edrophonium will supply acetylcholine, and this deficiency will be made up. And this is why the muscle power of the patient will improve. So that's the basis for edrophonium test for myasthenia gravis. The same test could be used to differentiate between what is called myasthenic crisis and cholinergic crisis. We are going to discuss this in details on the next slide. Edrophonium is also useful to reverse the nicotinic block by neuromuscular blockers, which I just described when I told you about physostigmine and neostigmine. That's the post-operative decurization, because edrophonium could reverse the effect very rapidly. The second test is not much useful. It's called provocative test by giving D-tubocurarine, but it's going to worsen the muscle power, and the test could be harmful. Now we come to what is myasthenic crisis and cholinergic crisis, and using edrophonium test for differentiation. You can have a look at the slide and listen to me. I am on the first column, that's myasthenic crisis. This is crisis, and it's myasthenic, means there is muscle weakness. So this particular situation is just like a patient of myasthenia gravis. The person in front of us is a patient with myasthenia gravis. He is already on management with anti-cholinesterase agents. What has happened is he is landed with severe muscle weakness. If it is myasthenic crisis, this muscle weakness is probably due to inadequate dose of the anti-cholinesterase agent which the patient is receiving. If it is due to inadequate dose of anti-cholinesterase agent, we call it myasthenic crisis. Now what we do is we give edrophonium in the dose of 2 milligrams intravenous. Let's imagine what's happening at the neuromuscular junction. This patient is on inadequate dosage of anti-cholinesterase agent. It means there is already less acetylcholine at the neuromuscular junction. Edrophonium is an anti-cholinesterase agent which is supposed to supply acetylcholine. The patient had less acetylcholine. Edrophonium supplies acetylcholine, so the muscle power of the patient improves. So the patient gets better and the muscle power improves. If the muscle power improves, it proves that this patient had less acetylcholine. It proves that probably the dose of the anti-cholinesterase medication which this patient was receiving was probably inadequate, was falling short, and this is why the patient was getting weakness. So we call it myasthenic crisis. Since we already know this has happened due to the inadequate dose, we need to increase the dose of the anti-cholinesterase medication. This is the approach for your myasthenic crisis. Let's go to the right side now. What's happening? Your patient is a patient of myasthenia and he is landed with weakness. Now once he comes with weakness, you don't know it's myasthenic or it's cholinergic. So our approach to this is giving edrophonium. Suppose it's cholinergic crisis. Why we are calling it cholinergic crisis? Because probably there is more acetylcholine at the neuromuscular junction, and this has happened because whatever dose the patient is receiving is becoming an excess dose for this patient. So you give edrophonium to this patient the dose of 2 milligrams intravenous, and if there's already more acetylcholine, edrophonium is going to add to this acetylcholine, so it will be still more acetylcholine, and this is going to lead to worsening of the muscle power and patient will appear more weak. If the muscle power worsens, it proves that the patient probably already had more acetylcholine, edrophonium added to it, and that's why patient got muscle weakness. It proves that this patient was receiving probably an excess dose of anti-cholinesterase agent. So the approach to manage this will be decrease the dose of anti-cholinesterase agent. So when a patient with myasthenia gravis comes with muscle weakness, it could be myasthenic crisis or cholinergic crisis, and you use Edrophonium test to differentiate between the myasthenic crisis and the cholinergic crisis. There's one more syndrome called Lambert-Eaton Syndrome. I'm bringing the discussion of this on this particular module because the symptoms of Lambert-Eaton Syndrome are similar to myasthenia gravis. In addition to this, 60% of the patients are likely to have small cell lung cancer. There's a presynaptic defect, and the defect is deficiency of acetylcholine release. There is an autoantibody demonstrated against voltage-gated L-type calcium channel. So this is the pathophysiology of Lambert-Eaton syndrome. What we can do is, we can non-specifically enhance the cholinergic neurotransmission. We can produce a non-specific enhancement of cholinergic transmission. And this could be done with the help of a drug called 3,4-DAP, that's 3,4-diaminopyridine. This is used by oral route of administration 4 to 5 times a day. What is it expected to do? It's expected to increase the acetylcholine release. It's expected to increase the action potential, and it is known to block the potassium conductance. Of course, the response to this particular drug treatment may be moderate to poor. We are not sure to treat this particular illness with this drug, but the important thing is we have a drug which could produce non-specific enhancement of the cholinergic neurotransmission. So that's 3,4-DAP. So what we discussed on this particular module was the cholinergic drugs. We divided the cholinergic drugs into directly acting and indirectly acting. There were esters of choline, there were alkaloids, and there were miscellaneous agents. In the indirectly acting agents, we had reversible agents and we had irreversible agents. One of them was physostigmine, which was useful for central nervous system effects. There was neostigmine and edrophonium, more useful for the nicotinic receptor site, that's the skeletal neuromuscular junction. And in the irreversible agents, we had organophosphorous compounds, and we discussed that this poisoning is one of the most common poisonings. That's why we need to know about the management of organophosphorous poisoning. This chapter is associated with the management of myasthenia, and that's why we discussed myasthenia gravis in details, the pathophysiology, the management, the diagnosis, and how to differentiate between the myasthenic crisis and cholinergic crisis. I am sure this particular module is going to be very helpful to you. Best of luck. Thanks for listening.